Good evening, everyone, and welcome to the Boston Medical Library's 13th annual J. Worth Estes Memorial Lecture. My name is J. Sankar, and I serve as the president of the Boston Medical Library. I want to thank you all for coming. In 1803, John Collins Warren, James Jackson, and some of the others started the Medical Improvement Society, which met to discuss medical papers. With their collection, they incorporated the Boston Medical Library in 1805 to serve the learning needs of the practicing physicians of the Boston area. It went into disuse in 1826. Can you hear me all right still? Or is it fading out? Still louder, okay. Pretty soon, there was enough need felt for a library in the Boston area. So much was happening across the globe. Rudolf Virchow was publishing his archives in Berlin in the mid-19th century, chronicling the cellular theory, identification of the leukemia cell, thrombosis, embolism, and the principles of public health infections. And right here in Boston in 1846 at MGH, surgical anesthesia became a reality. Again in Boston, Oliver Wendell Holmes linked hand washing to reducing puerperal fever in 1843, which was more widely publicized from Austria by the Hungarian Ignaz Semmelweis from 1847, but was rejected by the profession largely. Later in France, Louis Pasteur helped establish the germ theory, leading to Joseph Lister's antisepsis in Scotland by 1867. And just a few years later in Germany, Robert Koch was advancing bacteriology and sterilization. Surely, Boston needed a medical library for the practicing physicians. Through young James R. Chadwick's effort, the current Boston Medical Library opened its doors on Monday, October 18, 1875, with Dr. Oliver Wendell Holmes as president. In 25 short years, she built her own new building at 8 the Fenway, right across from here. And soon after that, the Harvard Medical School moved from Copley Place to the Quad here in 1906, and pretty soon found it frustrating to go across to the Fenway for a lot of references, because the Boston Medical Library was the one that had most of the collections. A 1958 gift from the Countway Charitable Foundation enabled the creation by 1965 of the Countway Library for housing the Harvard Medical Library and the Boston Medical Libraries, combined collections and all their services and functions, right next door, which we all passed by as we came here. The BML's current and historical collections of rare books, paintings, prints, artifacts, and others moved into the Countway and created one of the largest and most valued collections under one roof. And today, Chadwick would be proud to see the collaborative efforts of the Boston Medical Library, the Harvard Medical School, the Massachusetts Medical Society, to continue to expand the horizon from the ancient and current to a future including information technology, bioinformatics, and to being an active resource reaching out to help the learning of the profession through its life cycle, from the medical student, teacher, and researcher to the physician caring for one patient at a time in her office, struggling to find the time to learn the best way to do what she does best. Through all this, the BML never swerved from her original mission to improve medical care, and in the process, celebrate the history of the profession's continual struggle to do so. Captured in her motto, serveth et docet, to preserve and to teach. It's indeed an honor for the BML to present the 13th J. Worth Estes Lecture in honor of our late trustee, under the leadership of our committee chair, Dr. Dale McGee, who's sitting right here, and your committee for this wonderful lecture today. At Boston University School of Medicine, Dr. Estes was Professor Emeritus of Pharmacology and Socio-Medical Sciences. His medical publications include works in hematology and pharmacology. A respected, influential, innovative, and accomplished historian, he served as editor of the Journal of the History of Medicine and Allied Sciences. His work ranges from historical papers on the purple foxglove to medicine in ancient Egypt, naval medicine, Shaker medicine, opium, and on to quantitative observations of fever and many other subjects. Thanks to his late wife, Cindy Estes, for having funded and our former president, Dr. Leonard Morse, for establishing the J. Worth Estes Memorial Lecture Series. Please welcome Dr. Vincent Russo, a Boston Medical Library trustee and a classmate and colleague of the late Dr. Estes, to share his memory. Dr. Russo.
Thank you very much, Jay. I feel like a museum piece because J. Worth Estes and I were classmates in medical school. He was very, most of us were fresh out of college, and to us, J. Worth Estes appeared to be unapproachable. First of all, he was even taller than I was, and he was older than most of us because we graduated class of '60 from college, and it was 1960 we started medical school. J. Worth Estes, we called him just Worth, had gone to Harvard. He was born and raised in Lexington, Kentucky, went to Phillips Exeter for prep school, and then went to Harvard for college. And he graduated from Harvard in 1955, which was 5 years before the rest of us in the class. In that interim, he went in the Army for 2 years, went to Japan, and taught the Japanese how to speak English. He did a good job, obviously. They speak very good English now, so that's a joke. And then when he came back, he worked at the Mass General Hospital in the lab, and that's where he met Cynthia. They were fellow lab workers at the Mass General, and then they got married, and he then decided to go to medical school. Well, he needed to take a few more subjects, so he went to BU and got a master's, and then started with the medical class of 1964. Started in '60, we all graduated in '64. And although I mentioned how he seemed a kind of an intimidating figure, once you said hello to him and started talking, and then he had this accent because he was from Lexington, Kentucky, and most of the rest of us were from New England or New York, and it was unusual. He turned out to be one of the nicest, easiest people to get along with, and so helpful and willing to teach at a moment's notice. It was towards the end of our career in medical school, or at one of our early reunions, that he told me he had to give up horseback riding because he had developed plasmacytosis. What I gather is that it lasted the rest of his life until it caused a premature death in 2000, year 2000. So his wife and he left the money for this forum that happens every year. I'm very proud to be able to say that I was a friend of Worth Estes. Thank you.
Dr. Scott Podolsky is the director for the Center for the History of Medicine at the Colville Library. Would you please introduce our speaker, Dr. Shelley McKillop?
It's my honor to introduce Shelley McKellar, the Jason A. Hanna Chair in the History of Medicine at the Schulich School of Medicine and Dentistry at Western University in Ontario, where she has a joint appointment in the Department of Surgery. Such a joint appointment reflects her long-standing efforts to shed a reflective light on the practice of surgery and the ways that patient care, surgical, technological innovation, and emergent ethical considerations have co-evolved. It's also reflected in Dr. McKellar's interest in material objects as both research and teaching materials, and she's the curator of the medical artifact collection at Western, so we all have a great deal to discuss. Dr. McKellar's first book, Surgical Limits: The Life of Gordon Murray, examined the line between surgical innovation and hubris, and beyond its own merits, of course set her up for her present work. She was subsequently the co-author with Alison Kirk Montgomery of Medicine and Technology in Canada, 1900 to 1950, and the co-editor with Alison Lee and Elsbeth Heeman of the 2008 volume, Essays in Honor of Michael Bliss, Figuring the Social. The late Michael Bliss, for anyone here who didn't have the honor of knowing him, was the legendary author of The Discovery of Insulin and groundbreaking biographies of both Osler and Cushing, and was Dr. McKellar's PhD thesis advisor, and I suspect he'd be very proud here tonight. Dr. McKellar's forthcoming book, Artificial Hearts: The Allure and Ambivalence of a Controversial Medical Technology, will be published by Johns Hopkins University Press this fall. It traces, as she says, the history of an imperfect technology that speaks to questions of success, values, expectations, limitations, and uncertainty in a high-technology medical world that grapples with end-stage disease therapies. It's an important, instructive case study, and we're honored to have her speak here tonight on Spare Parts: Hope, Drama, and Dispute, Heart Transplantation and Artificial Heart Implant Cases in the 1960s.
Well, thank you very much for inviting me to be the 13th Estes lecturer. Thank you to the Estes family for actually endowing such an important series in terms of bringing speakers in and sharing their research. Thank you to Dr. McGee for looking after me so well, and Dr. Podolsky for actually inviting me here. I'm very pleased that in addition to the very kind introduction, you actually commented on the passing of Professor Michael Bliss, who passed away last Thursday. He was a very important influence in my career. He was my PhD supervisor and continued to be a very important mentor for me, and I'm positive I would not be in the position I am today without his guidance and influence. And one of the many things that he's taught me is that as an historian, we need to be not only respectful of the facts to understand kind of what happened, but also to understand the people and understand the events in terms of place and time mattering. He told me to not be afraid to talk to surgeons today about some historical surgical cases I've talked about in the past, but to also try to understand that case and all that it represented at that particular time. So in remembering Professor Bliss, I'd like to start today's talk by starting with the case. So meet the man who had three hearts, starting with his own native heart that was going to be replaced by an artificial heart, and then later replaced by a transplanted human heart. The man is Haskell Karp. He's a man from Illinois who had been battling heart disease for years. He's a very ill man by this time. The year is 1969, and he's 47 years old, and he has a severely damaged heart. He has suffered from extensive coronary heart disease and numerous myocardial infarctions for more than 10 years. During the 1960s, he had been hospitalized 13 times for heart problems, and in the late 60s, he received a cardiac pacemaker. So by this time, his heart is greatly enlarged due to the closed blood vessels of the heart and all the heart muscle scarring. He had advanced coronary arterial occlusive disease, he had myocardial fibrosis, and there was complete heart block. In the spring of 1969, Karp, now in end-stage heart failure, he traveled to Houston, Texas to see this heart surgeon, Dr. Denton Cooley, asking him to fix his heart. Cooley examined him and he suggested cardiac transplantation. But Karp was not so sure. Remember, this is 1969. And in 1969, heart transplantation was still an experimental procedure. There are no immunosuppressive drugs, and heart transplantation had a 75% mortality rate. So Karp was hesitant about agreeing to a heart transplant operation. Karp wanted his surgeon to perform first a myocardial excision with ventriculoplasty, or a wedge operation, with extensive restructuring of the heart ventricle. That is, the surgeon would go in and cut out all the damaged segment of the heart muscle and then basically rebuild the pumping chamber of the heart. So on April 4th, 1969, Cooley attempted to do just that. However, during the 3-hour procedure, Cooley found the damage to Karp's heart was too severe. And after all the excisions, there was just not enough healthy heart left to complete the operation successfully. So Karp's heart is fatally compromised by this time, and the patient would not survive once disconnected from cardiopulmonary bypass support. Thus, in a desperate attempt to save the patient, Cooley removed Karp's remaining heart ventricles, and he implanted a total artificial heart to keep Karp alive until a transplant operation could be performed. So Karp now had a new heart, an artificial heart, and it was keeping him alive. This is Haskell Karp after that implant surgery. He's alive, he survived the surgery, but what is most striking is the technology that's surrounding that, dare I say, successful surgery. Inside his chest was an artificial heart. His own damaged heart had been totally removed. Implanted in Karp was the Leota Cooley artificial heart. The device was named after Argentinian surgeon Domingo Leota, who was a key player behind the development of this device, as well as Cooley, who implanted the device. It was a 2-ventricle, air-driven artificial heart, which was lined with Dacron for blood compatibility, and it was encased in a celastic shell for durability. It's the approximate size of a human heart, perhaps a little bit bigger. There's a diaphragm inside the device, and it's modified to resist stress and wear. This is what's needed to pump each inner chamber shell to propel blood from one side to the other. Now, part of Karp's natural heart had been left in his body. That was the right and left atrial, and that's what the device is actually connected to, attached with Dacron cuffs and grafts. The device also attached to the pulmonary artery and the aorta, and this is what, of course, allows the blood to flow through the lungs and then into the body. Now, maybe some audience members have actually seen the Leota Cooley device that was actually implanted in Karp because it now resides in the Smithsonian's National Museum of American History in Washington, D.C. So that's the device, the artificial heart, that's actually inside Karp's chest. But what you see most is all the equipment outside of Karp's body. All of this technology outside of its body that's needed to power and to monitor the implanted mechanical pump. There's 4 long tubes, which you really can't see. If you look very closely, they were manipulated to be hidden for this picture. So there's 4 long tubes that are connecting the implanted device to a large power console. The large power console you see here on the right is about the size of a chest freezer. It sits at the side of the bedside. And inside that console, there's 2 major subsystems. There's the pneumatic pressure system that's needed to pulse the implanted device. And then there's also the monitor control unit, which is what watches the performance of the device. So it records arterial and chamber blood pressures, and it's monitored by usually an attendant there. And in this picture, this is a biomedical engineer, John Juergens, who can adjust the pressure as needed. So on one hand, it's very remarkable that Karp survived the operation, but he never really regains full consciousness. Cooley told reporters that the artificial heart implant had been an emergency procedure, that the artificial heart would remain in the patient only until we can find a donor heart for transplantation. Problem was they didn't have a donor heart. So Shirley Karp actually starts to make this nationwide plea for a heart for her husband, saying such things as, quote, "I see him lying there, breathing and knowing that within his chest is a man-made implement where there should be a God-given heart. Someone, somewhere, please hear my plea." So this makes for great media spectacle. You got a dying man being kept alive with a mechanical heart that had never been used before. You have a family now pleading for a donor heart, and indeed a donor heart was found. It was found way up in Lawrence, Massachusetts. So a medical team flew a 40-year-old brain-damaged woman, Mrs. Barbara Evans, from Lawrence, Massachusetts to Houston, Texas, keeping her alive until she reached St. Luke's Hospital in Texas, where she was then pronounced dead, and her heart was removed for transplantation, all to save the life of Haskell Karp. So, after living for 64 hours, about 2.5 days, with a mechanical heart, Karp now is returned to surgery, where they removed the artificial heart. Remember, that had been his second heart. And now he's now transplanted with a newly acquired donor heart, which now becomes his third heart. The newspapers love this. The newspapers printed stories of Karp's bold operations and the cross-country flight of the donor heart, complete with photos. Once the artificial heart had been removed from Karp, members of the artificial heart team anxiously began to study the device for any signs of mechanical failures. They reported none, which of course they did not hesitate to share with reporters. The interior surfaces and the valves in the device were free of thrombi, so there was no blood clotting. There was a smooth lining inside the device that consisted of fibrin and platelet deposits, all suggesting that there had been adequate blood flow through this device. Now you're asking yourself, this appears quite remarkable. It's particularly remarkable because the patient was not on any anticoagulant regime through this. So Domingo Liotta was happy to get in front of reporters, and he told them, quote, "The explanted device looked really wonderful," and he believed that Karp could have lived 6 months with it. Cooley reported that the device gave, quote, "a commendable performance as a simple mechanical pump." He did admit to some reporters that some hemolysis had taken place, but he wasn't sure if that was because of the bubble oxygenator while Karp was in surgery, or in fact the device had caused that problem. Nonetheless, both Liotta and Cooley were happy with the performance of the device, pleased to tell reporters that the artificial heart had worked well. So that was Karp's second heart. They should have been more concerned with that third heart, the transplanted heart, and the problem of rejection. Because remember, this is 1969, there are no immunosuppressive drugs ready to be implemented for organ rejection. And in the end, neither the artificial heart nor the new donor heart would be enough to ward off death for poor Haskell Karp. 32 hours after Karp had received his new donor heart, he died due to pneumonia and kidney failure. So what makes the Karp case so remarkable? Did the man with 3 hearts beat his struggle with heart disease and return to his family? No, he never left the ICU. And he lived only a combined total of 4 days with his artificial heart and his donor heart. Was he the first person to ever have 3 different hearts? No. In fact, the previous year, Cooley had performed 2 heart transplant operations on 1 patient. That man had had 3 hearts, although they were all human hearts. The double transplant patient died 3 days after his second transplant operation, but in total, that patient lived 202 days with his 2 donor hearts. One significant aspect of the Karp case is how it contributes to the allure and momentum for organ replacement in the 1960s. It fed into this promise of organ replacement that was being promoted in medicine and society at this time. It was an era of rebuilt people, according to this 1965 Life magazine piece. The Karp case was indeed the first implantation of a total artificial heart in a human, or the removal of one's native heart that would be replaced by a totally mechanical one. Arguably, Cooley would not even have attempted to implant this mechanical device had heart transplantation not been recently introduced. And indeed, what I'd like to argue is that these 2 new and very daring cardiac replacement operations, heart transplantation and artificial heart implantations, were very much intertwined in the late 1960s. And I would argue events and debates surrounding the heart transplant surgery shaped the development of artificial hearts in several ways. Again, very much intertwined, and I'm going to point out 3 connections. First, the introduction and later success of heart transplantation expanded the role of artificial hearts from their original indication. So at first, when researchers were starting to build these mechanical devices, they saw this as the permanent fix for diseased hearts. But remember Cooley, in that case that I started this talk with, Cooley didn't use it that way. He used the mechanical heart as a temporary device, as a bridge to transplant, as a way to keep the heart failure patient alive until a donor heart could be located and harvested and transported to the patient in need. So the artificial heart, during that time, had demonstrated its viability and working successfully as a bridge. I would also argue that the eventual success of heart transplantation helped artificial heart development. It didn't eliminate the need for artificial hearts entirely. Medicine and society's eventual favorable reception to the idea of artificial hearts was very much linked to the success of heart transplantation, this overall legitimacy, if you will, of organ replacement therapy. And I think this helps gain a place for artificial hearts alongside of heart transplantation. This is all part of what I would argue medicine society buying into replacement parts, buying into the idea that organs could be removed and substituted with other things, the idea of spare parts view of the body. human mechanical parts could be interchanged in a variety of ways. And thirdly, heart transplantation and mechanical heart replacement became further intertwined through these two Houston surgeons, Michael DeBakey and Denton Cooley, who were leading heart surgeons at the time and who both experimented with heart transplantation and artificial heart devices. So I think these connections of points are being intertwined, shape the development of artificial hearts, and are going to contribute to the debates that emerge at a particular place in time, the late 1960s, a lot of it coming out of Houston. But back to our CARP case. Why does it provoke such a controversy? Two reasons, I would argue. One, it raises the obvious debate about which procedure is going to be better for the patient in end-stage heart failure, a donor heart transplant or a mechanical heart implant. And also, the case of Haskell Karp is all about sensational drama. We have all sorts of medical, legal, and ethical entanglements. On the one hand, we have the media. They're celebrating the implant surgery as a triumph. Remember, the device had worked for 64 hours. And the media framed the event with the typical cast of characters. So there is the heroic surgeon, there is the brave patient, and of course there's the distraught family of the dying man making their nationwide plea. So journalists, of course, presented all of this story around this drama, presenting the procedure both as experimental, rescue-oriented operations, all in the interest of saving the life of a dying man. They clearly saw it as a last resort option. It had not resulted in a miracle recovery. But what's interesting is there was no blame attributed to either Cooley for Karp's death or the institution or the acts that were taking place at that time. That's interesting to keep in mind. There was blame, you could argue, unrelated to the events around Haskell Karp's outcome, more related, the drama, to allegations of device theft and clinical authorization of this experimental case. So the questions that came up were things like, did Mr. Karp and his family actually know what they had agreed to? Was Cooley overstepping his role as the cardiac surgeon? Dare say experimenting on his patient with a device that really wasn't ready for human use? And for those of you who may remember, it is the Karp case that is the event that caused the well-publicized rift between DeBakey and Cooley, when DeBakey accused Cooley of stealing the artificial heart device from his lab, walking it down the street to his hospital, and implanting it in his patient in a secret operation. This wasn't the Leota Cooley artificial heart. It was a device which had been collaboratively built by research teams at Baylor College of Medicine and Rice University with DeBakey's NIH research funding. Had grave surgical and professional transgressions indeed occurred? Now, I could have just as easily entitled this talk, A Tale of Two Surgeons and the Device That Launched a 40-Year Feud. DeBakey was furious when he heard about Cooley's artificial heart implant case. A great wrongdoing had occurred, and he refused to talk to or even be in the same room as Cooley for the next almost 4 decades. Now, again, to most people in the medical community, the names of Michael DeBakey and Denton Cooley are well known. During the 1960s, DeBakey and Cooley performed more successful cardiovascular operations, from valve replacements to aneurysm surgery, than almost any other surgeon in the world. Few, if any, other surgeons came close to matching the volume of surgery managed by DeBakey and Cooley, as thousands of heart patients made their pilgrimage to Houston, Texas to have their damaged hearts fixed. Both surgeons dared to operate when many others would not, and both of them introduced many new techniques arising out of their research programs. Let me take a moment here to just back up a bit and tell you a bit about each of these men and their relationships. Here's Dr. DeBakey. In 1948, Dr. DeBakey came to Houston, tasked with the job to bolster the surgical department at the Baylor College of Medicine. Baylor had just recently relocated from Dallas to Houston, and DeBakey was up for the task. DeBakey was a slight man, dark-haired. He's the son of a Lebanese merchant. He had just spent more than a decade at the School of Medicine at Tulane University in New Orleans. He had recently served with distinguishment during World War II, variety of medical operations, from mobile surgical units to important information about putting together the National Library of Medicine. And from the outset of his career, it's clear that Dr. DeBakey was an innovative surgeon. He was hardworking. He was very demanding of himself, which by extension meant he was demanding on his residents and his staff around him. He was driven to strengthen Baylor's struggling surgical department, but he was also determined to excel in his own surgical practice. And he accomplished both goals. Within a few short years, DeBakey established Houston as a cardiovascular center, and he established an international reputation as a cardiovascular surgical leader. And what he was known for his specialty in occlusive disease, or the accumulation of plaques, deposits in the blood that led to strokes and heart attacks. In the 1950s, he made this striking argument. He said, I don't need to understand the cause or even prevention of blocked arteries and veins. It's not necessary. It's not necessary because as a surgeon, I can simply bypass it. And it's DeBakey that devised grafts. First human grafts from cadavers and later plastic grafts from Dacron. And he used these grafts to redirect blood around obstacles in arteries that might otherwise rupture or cut off circulation. DeBakey repaired aortic and abdominal aneurysms, and he performed hundreds of these operations successfully at a time when most surgeons even refused to even attempt the operation. DeBakey's reputation grew. It grew as he took on more desperate cases. He received referrals from around the world, from across the country. And during the 1950s, DeBakey was practicing volume surgery at Methodist Hospital. He's performing more aneurysm and vessel surgery in 1 month than most surgeons did in 1 year. Whereas the Mayo Clinic became recognized for its large number of common surgical procedures, such as gallbladder removals and so forth, DeBakey is forging a reputation as performing the greatest number of complex vascular procedures with success. At the same time, DeBakey is also experimenting with mechanical cardiac devices to assist the heart as well as replace the damaged heart. Collaborating with researchers at Rice University, DeBakey and his research team developed several types of cardiac assist devices and a total artificial heart that DeBakey was arguing underscored, not resolved, underscored the technological and biological complexities of building an artificial heart device. This was no simple endeavor to replace the human heart with a viable mechanical device. So you've got to devise a mechanical device that will be able to live in a very hostile environment, the body, it's salty and so forth. You've got to build a device that can pump blood continuously and respond to your patient's activities, whether that patient was lying on the couch or climbing upstairs. Very ambitious endeavor to try to devise a mechanical device to do all of that. He's working away in his lab, and he thinks he's close. The year is 1963. He's done more than 50 animal implants with a cardiac assist device that he's come up with in the lab. He has a patient in his OR that he had performed an aortic valve replacement, but the patient cannot be sustained beyond the cardio bypass machine. He knows that this patient's going to die. So he brings his experimental mechanical heart pump and the assist device from the lab to use in his patient. 1963, first time he's going to use one of his experimental devices in the clinic. So what's intended to do is assist the pump by pumping the blood, propelling the blood from the weakened left side of the patient's heart into the descending aorta and out to the rest of the body. But it didn't work. It didn't work to save the patient. Dr. DeBakey removed the device, found that the device was clogged full of blood clots, was very distraught about that, and he returned to the lab quickly. And it would be another 3 years before he ever attempted to bring one of his experimental devices back into the clinic. 3 years later, 1966, DeBakey was ready to try again. This time, DeBakey invited Life magazine into his operating room to document the implant of his new and improved left ventricular assist pump. Now, clearly, this suggests to you that he's feeling pretty confident that this new device is going to work if he's inviting in a camera crew. And it was his newest device, but it was quite a different device from his earlier device of 3 years ago. His new device, 1966, was a device that was situated outside of the body. It had 2 connecting tubes that connected to the patient's chest, attaching to the left atrium and a systemic artery. But, like his earlier pump, It didn't work well enough to sustain the patient either. The patient died, even though this was a quite different device. But what's interesting is the Life magazine article that was brought in to document it actually celebrated the device. The article was celebratory of both DeBakey, what he was attempting to do, and this mechanical approach to assisting the heart. There is no controversial accusations launched against DeBakey or the use of the pump by either the media, the patient's family, or the medical community. And I just wanted to share with you some of the pages of this photo essay, 1966, in Life magazine. I love the subheadings used. A sudden and desperate crisis and a swift and measured response. So you get a sense of the tone of this Life magazine article. This is about medical suspense. This is about drama of a new procedure. Here's another good subheading. With the pump in place, a pause for the doctor. Phew, a job well done. But wait a minute, I just told you that this patient died. And in fact, the next patient that he used his new ventricular assisted pump on also died. And in fact, it wouldn't be till months later that DeBakey did report success with this new device, with this patient, Esperanza del Valle Vasquez, who after 10 days attached to the experimental pump made a full recovery. Vasquez was a 37-year-old woman who had undergone aortic and mitral valve replacement surgery, but her weakened heart failed to resume function after the surgery. So DeBakey resorted to temporary pump assistance. Very trial and error. He doesn't know how long it's going to be connected. He doesn't know how long she should stay on it. And he's monitoring closely. After 10 days, he assesses her native heart as resuming full function, and he's able to remove the pump quite easily. This case is celebrated as a success. DeBakey has demonstrated that his assist pump could be used successfully at what becomes known as a bridge to recovery. But these are assist pumps, helping the native heart do what it needs to do. The total artificial heart is a totally separate matter. And DeBakey pointed to obvious limitations here. DeBakey was quite clear through the 1960s that there was a lot of problems of actually building a viable total artificial heart. Problems with valves, weak arterial pressure levels, unknown blood interface performance, as well as many other limitations. And he concluded very clearly that there's just too many significant technical and physiological problems for a total artificial heart device to be used clinically anytime soon. But he encourages his research team back in the lab to keep working away. Bench research, animal research, and of course he's successfully securing NIH grants to be able to continue this line of research. Enter Dr. Denton Cooley. Denton Cooley joined the surgical team at Baylor College of Medicine in 1951 after he completed medical school at Johns Hopkins University, training under the cardiac surgeon Alfred Blalock, well known for his blue baby operations. The position at Baylor College offered Cooley the opportunity to work with another leading cardiovascular surgeon, Michael DeBakey, who of course was attracting at this time a larger number of cardiovascular procedure patients than almost any other surgeon in the United States. So for Cooley, who's anxious to get into the heart surgery game, he needs a place where he's going to see a lot of heart patients. The obvious place is to work with Michael DeBakey. Moreover, going to Houston was a homecoming for Cooley. 12 years younger than DeBakey, Cooley was a tall, blonde, native Texan who had been born to a family of wealth and social prestige. He had an outgoing personality, and he was well liked among his peers. He's already a talented surgeon, but Cooley joins DeBakey's team eager to learn more. He assisted DeBakey during the early surgical years of aneurysm bypass and vascular repairs. Soon, Cooley was performing countless cardiac operations, improving and refining his surgical techniques. Now, at this time, DeBakey was well known in American society due to the publicity surrounding those innovative bypass procedures. Remember, Life magazine's in there filming them. His mechanical assist devices, his research programs, his Dacon grafts, all of his aneurysm surgeries. And at this time, he's treating a lot of international leaders and celebrities, including he had operated on the Duke of Windsor and Marlene Dietrich, among others. Cooley's name was not as well known to the public. Yet in the medical world, the names of DeBakey and Cooley were soon linked. DeBakey and Cooley worked both independently and together in the operating room, and they co-authored numerous medical reports on their various surgical successes. But what was once a polite and professional relationship became quite detached and unfriendly by about 1960. And what's happening is Cooley is constantly battling to book enough OR space for his cases. And Cooley is beginning to feel the constraint of working in DeBakey's House of Surgery. So Cooley quietly began doing heart operations down the street, doing heart operations on children down at Texas Children's Hospital, while also continuing to perform cardiac surgery under DeBakey's service at Methodist Hospital. Then in 1960, Cooley officially left Methodist Hospital and he set up his own surgical practice at nearby St. Luke's Hospital. And 2 years later, he founded the privately funded Texas Heart Institute. Cooley did, however, retain his clinical professorship at Baylor College of Medicine. But after he shifted his practice to St. Luke's and Texas Children's Hospital, he rarely spent time in a Baylor lab. In Cooley's mind, he was skeptical that any experimental work that he was doing in DeBakey's lab would actually be useful to him in terms of understanding human physiology. In Cooley's mind, he'd rather be busy operating, doing more cases. And in fact, that's exactly what happens. His caseload continues to increase. So thereafter, early to mid-1960s, DeBakey and Cooley fell into an undeclared rivalry, according to some of his colleagues. Both were leaders in the field of cardiovascular surgery, although, according to many of their colleagues, DeBakey was seen as the vascular guy, Cooley was seen as the heart guy. Most surgeons acknowledged that Cooley was the more technically gifted surgeon than DeBakey. According to some of the surgeons that I've talked to over the years, they say that working with Cooley was exhilarating and impressive. Cooley's skill and expertise in doing so many heart operations made it look effortless, even miraculous. Surgical residents and visiting surgeons alike clamored to actually watch Cooley in operation. And remember, Cooley did not shy away from difficult procedures. This was clear, including the most daring and controversial operation of this period, cardiac transplantation. Heart transplantation captured tremendous public attention in the United States and around the world, for that matter, in the 1960s. The Stanford team, led by cardiac surgeon Norman Shumway, led the research pack in heart transplantation, and everyone expected that the first human heart transplant case would take place in California. But it did not. It was Christian Barnard who performed the first transplant operation halfway around the world in Cape Town, South Africa in December 1967. Barnard replaced the failing heart of 55-year-old Louis Wishkansky, who suffered from coronary occlusive disease, with the healthy heart of Denise Darvell, a 25-year-old woman with extensive brain damage due to an automobile accident. Wishkansky lived 18 days with his transplanted heart and died of pulmonary infection. Barnard's next transplant case, performed less than a month later, on January 2nd, 1968, produced better results. Philip Bleiberg, a 58-year-old white Jewish patient, lived over 19 months with his transplanted heart, setting a long-term survival record that other cases would aim to match. And it was this case that really energized the surgical world, attesting to the possibility that lives could be extended beyond more than just a few days. Unaware of Barnard's plans, American surgeons Adrian Kantrowitz and Norman Shumway were both preparing independently to go forward with their own human heart transplant cases after years of doing animal experiments. So 3 days after Barnard's sensational first operation, Kantrowitz performed the world's second human heart transplant in Brooklyn, New York. On December 6, 1967, Kantrowitz transplanted the heart of an anaphylactic infant into an 18-year-old baby, but the child died within hours. So this was the world's first pediatric heart transplant case. Across the country, on January 6, 1968, Shumway performed his first human transplant operation at Stanford University Hospital, but his patient lived only 15 days. Cooley and DeBakey soon get into the game, but they reported no better results. In May 1968, Cooley conducted his first heart transplant operation, transplanting the heart of a 15-year-old girl who had died of a gunshot wound to the brain into 47-year-old Everett Thomas. Within the week, Cooley performed 2 more heart transplants. And by April 1969, this is when Cooley implanted the artificial heart in Haskell Karp. By April 1969, Cooley had done more heart transplants than any surgeon in the world, a total of 19 heart transplants. But all of Cooley's transplant patients died within a matter of days. There's a little mouse that just ran along there. I'm not going to scream or anything. But all of Cooley's transplant patients died within a matter of days or weeks. At 6 months post-op, most patients were dead. In his group of transplant cases, Cooley has operated on adults, children, infants. He even transplanted a sheep's heart into a patient in a desperate measure to ward off death, and he never liked to talk about that case. But all patients succumbed to organ rejection or infection. Cooley remained frustrated with his mortality rate in comparison to the much better results of the Stanford team. Shumway, on the other side of the country, he's reporting a 42% patient survival rate at 6 months in comparison to a 10% survival rate recounted by most other surgeons. DeBakey, you just saw it too, didn't you? DeBakey was also in this elite group of surgeons daring to push the surgical boundaries through cardiac transplantation. Like everyone else, DeBakey battled organ rejection and infection in his transplant patients. However, he reported 2 remarkable cases. DeBakey transplanted his first heart on August 31st, 1968, as part of a spectacular multiple transplant. Listen to this. This is quite spectacular. So this is the case in which a donor's heart, lung, and both kidneys were transplanted into 4 different people in 4 different operating rooms at Methodist Hospital at the same time. DeBakey's in the OR that's going to be transplanting the heart. So he implants the heart into his patient, and that patient that he transplanted the donor heart into lived almost 3 years and 9 months with that heart. In another remarkable transplant case that DeBakey's involved in, DeBakey's patient actually lived more than 6 years with a donor heart. DeBakey performed 6 more transplant operations during the fall of 1968, but then the number of his transplant cases declined noticeably as the whole medical field was beginning to reevaluate the procedure as a whole. And the purpose of this chart is basically to show you that these early heart transplant operations and who's actually playing in the game of trying to push the boundaries that much further by doing successful heart operations. In the year 1968, more than 100 transplant operations were done worldwide. Who's leading the pack? Cooley, Shumway, and DeBakey have performed the greatest number of cases. Transplant operations took place in roughly 20 countries around the world. The majority of these are taking place in the United States. But it was only a matter of days or weeks that these early transplant patients actually survived. Remember, we've got a 75% mortality rate. So it's clear that heart transplantation is very much still an experimental procedure. And at this point, medical and public disillusionment with heart transplantation sets in. By the end of 1968, mounting medical criticism and poor patient outcomes deterred many surgeons and patients from participating in cardiac transplant operations. Cooley, Shumway, and DeBakey supported the lessening number, but not necessarily the abandonment of heart transplantation. As the medical community debated the wisdom of pursuing transplant operations, the spotlight on cardiac replacement abruptly shifted from human hearts to mechanical ones, with the first clinical implantation of an artificial heart. And so it was at this point, on April 4th, 1969, that Cooley implanted an artificial heart in Haskell Karp. Now, earlier in 1969, remember that DeBakey had stated that the total artificial heart was not ready for use in humans. Obviously, Cooley disagreed. The Karp case had occurred in relative secrecy with blatant disregard for experimental surgery procedures, and this brought about the immediate launching of national and local investigations. Without delay, Theodore Cooper, director of the National Heart Institute and National Institutes of Health, asked, was the device used in the Karp case developed with the assistance of NIH research money? If so, did surgical researchers adhere to federal guidelines relating to the collection of experimental data and the decision to move forward to clinical use? DeBakey led the largest federally funded artificial heart research program in the country, so most assumed that the device had emerged out of his lab. However, DeBakey had no knowledge of Cooley and Liotta's collaboration on the development of an artificial heart, and he'd only learned about the actual Karp surgery after the fact, when he was in Washington, ironically, at a meeting at the National Heart Institute. Moreover, DeBakey at this time was president of Baylor College of Medicine, at which both Cooley and Liotta were on staff. DeBakey is embarrassed. He's angry. This is threatening to tarnish the reputation of his college, of which he's now president. It's going to threaten his artificial heart program. Was DeBakey not in control of his institution and his personnel? In response to Cooper's questions, Cooley stated that he had developed the artificial heart used in the CARP case from private funding, not federal funding, and so NIH guidelines simply did not apply. And this was in fact true. Cooley had not applied for nor received any NIH research funding, so Cooper let the matter drop. But the Baylor College investigation, led by a committee appointed by Baylor trustees, did pursue the matter, since Cooley had not gained Baylor permission to use the device from the Baylor Committee on Research Involving Human Beings, which is a group of doctors who could have easily assembled for this emergency decision. Cooley defended himself by saying, there just simply wasn't enough time, and I had informed consent from Karp and his family, and I needed to act quickly for my patient's sake to save his life. Cooley also acknowledged that the surgery was a desperate act, but again, this reflected a surgeon's obligation to do everything possible to save the life of his patient. He said he had not been motivated to perform the operation for the sake of testing the artificial heart to see if it actually worked in humans. Still, many raised an eyebrow when it came to this. Was Cooley really authorized to proceed with this operation? Wasn't it unethical to proceed with such an experimental procedure without a broader hospital or medical committee review? In the end, the Baylor Committee recommended censoring Cooley for ignoring institutional policy that was in place to protect the rights of patients. The American College of Surgeons also agreed, and they censored Cooley. A defiant Cooley commented that he would do it again, refusing to bend to the will of a committee that he said, in his opinion, was simply controlled by DeBakey. In an attempt to avoid another incident like Haskell-Karp, Baylor administrators created a new Baylor College appointment form that required mandatory faculty compliance with the rules of the Committee on Research Involving Human Beings. So a form was sent around, everyone had to sign it. Cooley refused to sign it. He said, I refuse to sign it. This is just a way of DeBakey to control my actions. And in the end, Cooley resigned from Baylor College over the issue. Now, losing his affiliation with the Baylor College of Medicine was of minimal significance for Cooley. He simply continued his surgical practice and research at the Texas Heart Institute. Domingo Leota's involvement in all of this is much more questionable, and his actions support DeBakey's accusation of device theft and betrayal. In 1964, Leota joined DeBakey's artificial heart program as a researcher, for which an NIH research grant paid his salary. Also in 1964, DeBakey's research team at Baylor began collaborating with engineers at Rice University towards developing an implantable total artificial heart device, of which Leota was part of. This collaboration produced various mechanical pumps, both assist devices and an implantable total artificial heart. In early 1969, the Baylor Rice team actually was beginning to test the Baylor Rice total artificial heart in animals and had conducted 7 calf implants with very poor results due to implantation and device problems. And looking at these records certainly supports DeBakey's position that in April 1969, the total artificial heart was not ready for use in humans. At approximately the same time as the Baylor Rice team are doing these animal implants, testing the total artificial heart, Leota starts to moonlight for Cooley. So Leota starts working double duty for both Cooley's program and DeBakey's program. Whereas DeBakey moved cautiously in his research program, Cooley tempted Leota with plans to use the artificial heart in a patient sooner, and this enticed Leota to actually begin working with Cooley. And Cooley requested that Leota not tell Dr. DeBakey about this. Do not inform your Baylor boss, and certainly DeBakey would shut this down, would have prevented Leota from working on both research teams simultaneously. Leota defended his secrecy by saying that, well, this will be okay because I'm going to work on a totally different device under Cooley's research program. But no one believed this. The Leota-Cooley artificial heart was practically identical to the Baylor Rice artificial heart. And I think it's implausible that Leota could independently build a new device in just under 4 months. And in fact, to a Life magazine reporter, Thomas Thompson, Leota admits that he, quote, stuffed parts of the DeBakey artificial heart in his briefcase and took them down to St. Luke's Hospital, end quote. So fuming, DeBakey openly charged Cooley and Leota for covertly taking the Baylor Rice artificial heart from Baylor to St. Luke's Hospital for implantation in CARP. DeBakey fired Leota, and Leota then went to work full-time for Cooley as a surgeon and researcher at the Texas Heart Institute. For days after Karp's death, the artificial heart news stories continued. They're focusing on the accusations of device theft and the clash between the two famous surgeons, the Texas Tornado versus Dr. Wonderful, as one Life reporter dubbed DeBakey and Cooley respectfully. The news coverage highlighted the surgical and technological first of the artificial heart implant, and of course that dramatic flight of the donor heart across the country. The more complex issues of medical effectiveness and medical ethics was not raised by journalists in any meaningful way. But the medical community did discuss these issues. They did discuss these issues seriously, both informally and formally, at professional meetings and in the medical literature. And one of the more interesting professional discussions was the query over which cardiac replacement procedure, heart transplantation or artificial heart implantation, promised to be the better therapy. Where should we be putting our bets behind? Where should we be really focusing our attention on? Which one's line of inquiry should we be supporting? The medical community bluntly asked, should human or mechanical parts be used to save the dying heart failure patient? And as you would expect, sides are going to be drawn. Both DeBakey and Cooley came out in support of mechanical hearts. Arguably, DeBakey was simply defending his research empire. He ran the largest artificial heart research program in the country. He's the one with the multi-million-dollar NIH research grants at stake. DeBakey stated that artificial hearts would be similar to the artificial kidney. It would provide necessary patient backup when cardiac transplant operations fail. Also, DeBakey argued that mechanical hearts would overcome the problem of supply or donor heart availability. And this would help circumvent many of the moral, ethical, and legal issues surrounding human transplantation. Now, I think DeBakey really failed to consider that there would be similar moral, ethical, and legal entanglements around artificial heart. And of course, these came out to bear and were discussed during the 1980s. Cooley also came out on the side of mechanical hearts. And in a medical conference in Chicago in 1969, he made this bold statement. He said that cardiac transplantation should be considered a stepping stone toward a mechanical heart. The mechanical heart would be the more practical treatment for patients with fatal heart disease. Now, several years later, he backpedals a bit, he softens his position here, and he encouraged a two-stage cardiac replacement approach. So the temporary use of mechanical devices followed by the transplantation of a human heart. So that was exactly as he had done in the Haskell-Karp case. Clear opposition to DeBakey and Cooley is Shumway. Shumway argued against the mechanical heart, stating that, quote, the darn thing is really very dangerous, end quote. Shumway did not support their use as a temporary measure, as Cooley suggested. In his opinion, there were problems with the device materials and the threat of blood clotting, which could kill the patient before their transplant surgery. Furthermore, Shumway pointed out that the use of artificial hearts did not eliminate the problem of too few donor hearts, but instead simply shifted the patient with the artificial heart to the top of the priority list, thus raising issues of fairness and access to the whole process. In the end, the medical profession situated cardiac transplantation and mechanical hearts as complementary rather than competitive lines of investigation. Because in the 1960s, neither of these approaches really worked. All heart failure patients died as neither therapy was yet perfected. After the initial rush of transplants, 1968 and 1969, surgeons performed significantly fewer heart transplant operations, awaiting the introduction of cyclosporine in 1980 that countered organ rejection and increased survival rates of transplant patients. And I think this graph shows very well the significant rise in transplant surgery after the introduction of cyclosporine. Shumway was right. Researchers would overcome the central limitations of transplant surgery before those of the artificial heart. Nevertheless, work on artificial hearts continued, with no less commitment and belief in its eventual fruition by many researchers in the field. After the Haskell-Karp case, a bitter DeBakey resumed his research on the Baylor Rice artificial heart, as well as his cardiac assist pumps, but he refused to speak to or even acknowledge Cooley for the next almost 40 years. Now, I'm all one for happy endings. So let me show you this picture and tell you that in 2007, DeBakey and Cooley buried the hatchet. They shook hands, they chatted in good humor when DeBakey accepted a Lifetime Achievement Award from the Denton Cooley Cardiovascular Surgical Society. Later, DeBakey Society reciprocated in honoring Dr. Cooley. DeBakey was 99 and Cooley was 87 years old. To conclude, the goal of cardiac replacement through the new and daring procedures of heart transplantation and artificial heart implants was not abandoned, despite the poor patient outcomes of the late 1960s. At that time, these two different heart replacement procedures were intertwined, as they would be again in the 1980s. The debate of which procedure was better, was the mechanical heart a better option than a donor heart? Well, that was not resolved in the late 1960s. The debate had only just begun. Haskell Karp, the man who had 3 hearts, was indeed a sensationalized and controversial case, complete with feuding surgeons. The case showcases the hopes and realities of the 1960s, both the allure of organ replacement in medicine society, but also alongside the very real limitations of cardiac replacement procedures at this time. For many, this 1969 controversial case of implanting a total artificial heart was a one-off. It was an isolated event that dare not be repeated. The device implant had been a clinical first, but the procedure had not saved the patient's life. The artificial heart was premature technology, said the medical majority. Some said the case smacked of human experimentation. Still, despite the controversy, in the end, the Karp case did not detonate the artificial heart program, nor discourage artificial heart researchers who continued on their work thereafter. Did the 1960s Karp case end the clinical use of artificial hearts in the US? It did not. But the next human implant case did not take place for another 12 years. And guess who performed that surgery? Yes, Dr. Denton Cooley, amidst similar media attention and troubling patient outcome. But you'll have to invite me back to hear that story or read about it in my forthcoming book. Thank you very much. Sorry to have got distracted by the mouse, but I saw him run all the way down the stairs, and I thought, where is he going? Oh, my gosh.
Thank you for a wonderful presentation. I think you can really say it was a stirring presentation. You know, there's not even a mouse moving. That's before Christmas. This is not Christmas. But even the mouse was moved, and everybody roused with a wonderful presentation.
Thank you very much.
Thank you for the question. Okay.
I'm happy to answer some questions, and I even did a little bit of research on when was the first heart transplant here? Is anyone in the audience was here when the first heart transplant here in Boston occurred? I figured there'd be somebody in the audience that could tell me a bit about it. How about, does anyone know the first artificial heart implant here in Boston? First VAD was in '91, and it was in 2012 with a SynCardia total artificial heart. So I was waiting to see if there was someone actually part of those surgical teams that was here in the audience that would ask that question. I came prepared. But I think this is a great picture. So people involved.
Before we go on to questions, you did a lot of research. You brought us towards the current time. Tell us where it's going to go. But thinking about their questions.
I always get asked that question, so I can play the I'm an historian card and say, I don't look in the future, I look into the past. But one thing that I've learned, and of course this is one of the key moments that Professor Bliss had always taught me about not to engage in the events that they are today and to talk to people about them, is I became struck by the commitment a lot of these people are involved. And when I've toured different programs that do these implants at Cedars-Sinai, I was just impressed by the people that are living today with these SynCardia total artificial heart implants, or particularly these left ventricular assist devices. I think after former Vice President Cheney was implanted with his HeartMate 2 VAD, that actually has brought a greater awareness to people about the role that mechanical devices can play. There's less reluctance to it. I think in terms of transplantation, I don't have to tell this audience, in terms of organ transplantation, it has always been a field, whether it be from kidneys moving through to other organs, an area which has only expanded with greater and greater improved patient outcomes, that we see people participating in transplant games, running marathons and all of that. So I think that's encouraging. I think many of the medical students sitting in the audience probably, as they're going to do surgical residencies, will be very involved in some of these new innovations.
Anyone have any thought, any comments, any thoughts about how people did this and reacted to each other? Yeah, please.
Did Dr. Barnard take any stand on the feud?
Dr. Bernard? Christian Bernard's an interesting character because he was not well liked. So he tried to be very gracious, but of course he knew Shumway from his training under Dr. Lillehei, and they were very, Shumway didn't like Bernard, and they were opposite personalities, so it was very much an at-arms relationship. And of course he was invested in heart transplantation as a procedure to be developed in his in Cape Town. But of course he enjoyed the media attention after being the first one to implant, and of course didn't actually perform a lot of transplant surgeries thereafter. And Dr. Shumway was always very gracious, even though you know that must have been difficult for him not to have been the first to actually do the first clinical case, but he was always very gracious. And he always said that in one way he was grateful that all the media spotlight went to Christian Bernard and not to himself at Stanford.
Somebody had a question? Yeah.
It's well known that Bernard and DeBakey and Cooley had larger-than-life personalities. They were very much invested in themselves. Do you feel with your detailed study that that's what it takes to make these great strides in medicine, medical innovation?
That's interesting, and I know there's been different works done essentially with neurosurgery as well, to kind of the outlook of the surgeon. I mean, you have to have a certain amount of confidence and bravado to go and to even attempt these and to be able to actually go back into the operating room thereafter. John Gibbons, after his fourth patient case, couldn't bring himself to go back in to do that again. So I think with both Dr. DeBakey and Dr. Cooley, and I never met Dr. Bernard, but they are larger-than-life characters. I remember attending a medical meeting, and when Dr. DeBakey walked into the room in his elevator shoes, because he was conscious about that, the room went dead silence. It was like someone sucked the air out of the room. He had such presence into that room. And he was a larger-than-life character that I think he himself created it, and I think that we, as an audience, also gave him. I think it was a two-way street that we wanted that larger-than-life personality. Dr. Cooley, incredibly charming and disarming and lovely man, a certain amount of bravado. Do they need to have those kind of characteristics to go forward? They have to be risk takers. I think the surgical personality has been written about in terms of is there a personality type that allows you to be a surgeon versus a pathologist versus a researcher? Do we have any surgeons in the audience? Maybe they can speak to that. Maybe you can speak to that. Do you have a larger-than-life personality?
Of course.
Of course.
Well, thank you very much. Thank you all for the wonderful.
Thank you.